HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
I will be speaking to Dr. Alessandro Fois on Parkinson's disease and its management. Dr. Fois, tell us about yourself.
Thanks for having me on, David. So I'm a neurologist based out of Sydney. I work at Macquarie University Hospital and also in my private practices in North Sydney and at the Woolcock Institute in Glebe. And I also do a visiting neurologist service to Hervey Bay in Queensland, a regional clinic where I do face-to-face clinics and telehealth. My clinical and research interests are mainly in movement disorders like Parkinson's disease and tremor. And I'm also very interested in telehealth and its expanding role in lengthening the reach of neurological care throughout Australia.
Dr. Fois, thank you once again for being with us. You've given us an incredible talk on the diagnosis of Parkinson's disease to the point of referral. We now come to the management of Parkinson's disease. Just briefly, what are the orthodox and conventional treatments and what is new and when do you use them and how effective are they?
Yeah, thanks, David, and thanks for having me back again. So this is a really common question I get in clinic as well. Patients will come in, either new patients or existing patients, and say to me, what's new in Parkinson's? I heard about this new drug in the PBS. Let's try one of these modern treatments. And I find it useful to go through with them, and I'll go through this now, the sort of framework of treatment and a bit of the history of the treatment of Parkinson's as well. So one of the oldest medications for the treatment of Parkinson's disease is the levodopa. Mm-hmm. And this has been around since the 1960s for treatment in humans. And the levodopa is the trade names you'll be familiar with are things like Matapar and Sinemet and Kinson. And it's given the levodopa together with a decarboxylase inhibitor like benserazide or carbidopa. And just to sort of explain that in a little bit more detail as a refresher, levodopa is converted to dopamine. Mm-hmm. And we want the dopamine in the brain because it's going to activate the dopamine receptors, allow the patient to move and suppress the tremor. But we don't want the dopamine in the body, in the systemic system, where it's going to make the patient vomit. Because as you know, dopamine blockers like metoclopramide are used to treat nausea, and dopamine really promotes nausea. So we give the levodopa in combination with a decarboxylase inhibitor. The decarboxylase inhibitor cleverly does not pass the blood-brain barrier, breaks down the levodopa in the periphery, so it doesn't lead to dopamine buildup in the periphery, doesn't cause nausea, but allows the levodopa to be converted to dopamine in the brain. Now, this is one of the oldest treatments for Parkinson's, but it also remains the most powerful. So patients are sometimes a bit miffed, saying, why are you putting me on this medication that has been around since the 60s? But even though it's the oldest medication, it remains the most potent and the most powerful. So generally speaking, when I'm initiating a patient on treatment, I'll generally choose levodopa. And actually, I just want to make one other comment, because even before getting on to which treatment to choose, I have some patients with early Parkinson's disease who say to me, do I really need treatment right now? Mm-hmm. Or they say to me, I don't want to take treatment too early because I read on the internet that if I take levodopa, it's going to cause side effects like dyskinesia. And I've seen the documentary with Michael J. Fox, and he's got so much dyskinesia, and I don't want to accelerate that happening to me. Dyskinesia, is for your listeners who might not have seen it much, are these involuntary wriggly movements that patients can get as a side effect from the levodopa. And there was a study done a couple of years ago in the Netherlands to address exactly this question. If someone has early Parkinson's disease and we treat them immediately with levodopa, or we defer it for a year and then treat them, and that's what they did in this study in a randomized way, doesn't make a difference to their outcome in 2 or 3 years' time? And the answer is no. So whether we initiate treatment early or whether we defer it is not going to accelerate or slow down the underlying course of the Parkinson's disease. And this is something I talk through with patients because it often really simplifies the decision of whether or not to start treatment. And I say to people, look, I'm in the business of making you feel better, not making myself feel better.
Mm-hmm.
So you're asking me, should I start treatment? I'm going to turn that back to you. Is this tremor or stiffness or slowness, is it bothering you? Is it interfering with day-to-day life? And if they say no, and I'm a bit anxious about starting treatment, I don't really want to, I say, that's fine. There's no boat we're going to miss here. If you come back in 6 months and you've changed your mind, we'll start treatment then. Or if in the car park you change your mind, you call my office, we'll start treatment. It's no big deal. So I find that knowledge from the research landscape that when treatment is initiated doesn't influence long-term complications really diffuses the tension about whether or not to start treatment. So in terms of which treatment to start, I usually start with levodopa. And I do it in a particular way where when I started, my main focus is to avoid the patient getting side effects because, they're going to be on a long journey with the Parkinson's. And oftentimes there's no big hurry to really get them on a big dose of medication quickly. And I think it's better to start at, my view is it's better to start in a gentle way to minimize the risk of side effects. In particular, side effects of nausea or dizziness on standing. Those would be the sort of commonest things. And the way I try and avoid that is by starting the levodopa really gradually over 6 weeks. So I'll typically start people on 50 milligrams of levodopa once a day. So half of a Matopar 100/25 or half of a Kinson 100/25. And then increase the dose by 50 milligrams of levodopa each week until they're taking 300 milligrams per day. So, 100 milligrams 3 times a day of levodopa. And the other trick that I use early on in Parkinson's is I actually tell the patient, take the levodopa with food. And this causes some confusion because when they go to the pharmacy, the pharmacist tells them take them, but take it on an empty stomach. And so I tell them this before they even go to the pharmacy, that there's going to be this confusion. But the reason for it is that it's true that the food interferes with the absorption of the levodopa. But early on in the Parkinson's, I try and use that as a bit of a trick to blunt the effect of the levodopa and blunt any side effects. Because I'm more concerned about minimizing the risk of side effects initially rather than getting them onto a big and effective dose. So my thinking about starting the levodopa is just to start it gradually and then also take it with food initially. And then the third pointer I would give is actually, even after I've got the patients on my initial dose of, say, 100 milligrams 3 times a day or 300 milligrams a day of levodopa, I usually give it another 6 weeks or so to really see the full effect of that dose before trying to increase it further. Because we know that with the levodopa, even though it's got a very short half-life, the half-life is 90 minutes. So within a few hours, it's left the system. But we know it also has a long duration effect, which can last even days after the drug is ceased. And so, and that long duration effect builds up. So initially with Parkinson's, I generally give it at least a few weeks to see what effect the initial dose has before ramping it up further. So that's my general approach to initiating levodopa. The other comment I would make is there are other drugs out there that can be used for initial therapy, and then some people might use for initial therapy, such as MAO inhibitors like rasagiline, also known as Azilect, or dopamine agonists like pramipexole, or also known as Cifrol. And just to comment on those two, so the rasagiline has a much milder and more modest effect than the levodopa. So I find I very seldom use it as initial therapy, and usually only in patients who are very, very concerned about starting the levodopa. They want to take something. They're not too worried about having a big impact. And so the rasagiline might be a good fit for them. And then for the dopamine agonists, like the pramipexole. So this is an interesting class of medication because they come in an extended release formulation. They can be long acting and once a day tablet, and they have lower risk of causing these dyskinesias that the levodopa can cause after a few years of therapy, this kind of wriggly movement that can happen as a peak dose effect an hour after taking the levodopa. And so you might think, gosh, why don't we just start everyone on dopamine agonists? Surely that's a better choice of drug. You know, it's once a day, has a smooth effect, lower risk of dyskinesia. And indeed, historically, there was a period of time when people thought that was a great approach. But what we've come to a growing realization of with time is that the dopamine agonists, especially at higher doses, have significant risks of sort of neuropsychiatric side effects. So people can get this impulsive behavior, gambling, too much time on the internet, too much interest in sex, which might sound sort of quaint or amusing, but can have a really devastating impact on people's lives. And, you know, you see some people where they've spent some time on a very high dose of a dopamine agonist and they've gambled away their life savings, or they've gained a lot of weight through binge eating, or there's been a lot of friction at home with their partner due to inappropriate sexual behavior. And so, or indeed hallucinations is another side effect. So there's an increasing realization that there are risks associated with higher and higher doses of the dopamine agonists. So it's an individualized choice. There will be some patients where I treat them and they're intolerant of the levodopa, my first choice, and then we might switch to a dopamine agonist and we'll do that. But generally speaking, in terms of the batting order, I would typically start the levodopa first and increase it in that very gradual way.
At what point would you say that oral therapy is insufficient or the adverse effects is significant and another adjunct therapy, be it medications or surgery or devices, might have a role to play?
Yeah, so let me give, in answering that question, let me give a little sketch that I sometimes give to patients of, you know, what might the timeline of Parkinson's look like? Because people will often ask me, you know, what's the prognosis? What does the future hold? Which is an incredibly difficult question to answer. But let me give a bit of a broad sketch. The data tell us that most patients will take, let's say, the levodopa for a few years. And what's a few years varies person to person, but let's say about 3 years, with a very smooth effect. So they'll get a good long duration effect from the levodopa. Even though the half-life is 90 minutes, it'll last 8 hours or longer. They'll just take the levodopa 3 times a day with a very smooth effect. They won't feel it wear off, and they'll get on with their day-to-day activities quite well, including working, driving, etc. This is a very broad sketch. After a few years, what can happen is that people notice some ups and downs or fluctuations over the course of the day, where they take the levodopa, let's say at 8 in the morning, and then before it's time for the next dose at 12 or 1 or 2, they notice it starts to wear off. The tremor, stiffness, and slowness starts to come back before they've got they're due for the next dose. And we call that phenomenon wearing off. That's the technical term. And they might also notice, that's the down part of this, but the up part of the ups and downs is that they might notice the levodopa has too much effect. And typically an hour after they take the levodopa, they get a sort of overshoot effect on their movement and they get excessive movements, which can take the form of wriggling movements affecting any part of the body. It can be the neck, the arms, legs, mouth. Or they might get cramp and sort of inturning of a foot or cramping of their leg or hand. And We call that phenomenon dyskinesia. And interestingly, it's often noticed more by the partner than the patient. The patient often doesn't notice the dyskinesia too much, and the partner might be more attuned to it. So after a few years with the Parkinson's, people can get these ups and downs, and I hasten to add that this is not related to the levodopa poisoning the brain. It is due to the Parkinson's gradually progressing in the background, and the brain losing its capacity to translate the levodopa into a smooth effect. So when patients say to me, I want to defer starting the levodopa because I want, I've got 3 years before I get the dyskinesias, I want to wait and have those 3 years later, I say to them, I don't think that's how it works. That's not what the data tell us. Whether you start now or start later, it's not going to affect when the absolute date of when the dyskinesias is, if they happen, it's done. So let's go back to our patient with Parkinson's. It's been a few years on levodopa. They've started to develop these ups and downs, the wearing off and the dyskinesia. There's a few strategies we can use to address that. One strategy is to bring the levodopa doses closer together, and we might even reduce the dose and bring it closer together. By reducing the dose, we kind of reduce the peak effect and reduce the dyskinesia. And by bringing it closer together, we're trying to get rid of those troughs and get rid of the wearing off. So that's one strategy. There are limits to that. I find often you can't bring the levodopa closer together than about 3 hours before it starts to stack up and cause chaos. But one approach is to bring the levodopa closer together and maybe reduce the dose to treat the dyskinesias. Another approach is some of these add-on medications from other classes or adjunctive medications, like the MAO inhibitors, like rasagiline or sulfonamide, the COMT inhibitors, like entacapone, or this new drug, opicapone, that patients might ask about. It's just made it onto the PBS this year, opicapone or Ongentys, or dopamine agonists, like pramipexole. And so these are drugs that can be taken together with the levodopa to try and get a smoother effect over the course of the day and address this wearing off in particular. So that's where those additive drugs have, in my experience, have the most benefit, is in that situation with the wearing off. There is a little bit of research to help guide us about which one to choose. And I remember reading a sort of head-to-head comparison between them that suggested that the MAO inhibitors are maybe a little bit better compared to the COMT inhibitors. So things like rasagiline or sulfonamide. But I caveat to say that particular study I'm referring to didn't include the most modern COMT inhibitors like opicapone. So that was a key weakness. It didn't include some of those more modern drugs. In that sort of typical patient I've talked about, where they're experiencing that wearing off phenomenon, if I'm going to add something, I might add in rasagiline or sulfonamide to try and address that wearing off. The opicapone is also a very reasonable choice, and I have some patients where I use that. I don't use the entacapone quite so much. You might have encountered that as a combination pill with levodopa carbidopa, something called Stalevo. I find the entacapone for many patients can cause sort of gastrointestinal side effects, and I've had a few patients just not tolerate it. But equally, I've seen some patients where they've been on it for years and they've tolerated it for just fine. So it's not my first go-to for that reason. So going back to the sort of typical Parkinson's timeline, you might have a few years of really smooth response, and then a few years of more ups and downs that we try and smooth out by making the medication regimen more complicated, bringing the levodopa closing together, or adding adjunctive therapy. And then for some patients at that point, after we've made the drugs have become more complicated, but we're still struggling to address these fluctuations, the wearing off of the dyskinesia. At that point, some patients might consider a device-assisted therapy. And there's a few examples of this. So there's the deep brain stimulation involving electrodes, so holes drilled in the skull, an electrode deep inside the brain into a deep target, and then a pacemaker battery in the chest. But there are other device-assisted therapies as well, including the duodopa pump or levodopa carbidopa intestinal gel. So this is a pump that pumps a gel formulation of the levodopa into a tube that is a jejunal tube. So it goes through the abdominal wall into the jejunum, and the patient wears a pump hooked up to this PEJ tube, which pumps the medication in at a steady flow rate. So the idea there is, okay, we're avoiding this pulsatile stimulation of the brain with doses of levodopa every 3 hours, and instead they're just getting a really steady flow through the pump. Or the other sometimes used device therapy is the apomorphine infusion, which is the least invasive of the device therapies. The patient has a subcutaneous butterfly needle into the skin of the abdomen, and then they also wear a pump which pumps a steady stream of this dopamine agonist apomorphine into the skin. Apomorphine's got nothing to do with morphine, it's a dopamine agonist. So that's the other device-assisted therapy that's sometimes used. In terms of the sort of batting order, if you like, the DBS and the duodopa intestinal gel, roughly equal in terms of how powerful they are, but patients might have a preference towards one or the other. Some patients, have a preference towards, or let's say, differing degrees of abhorrence of the idea of the skull being drilled into or having a tube coming out of their abdomen. And so there might be patient preference, but there might be other clinical factors causing one to be a better choice than the other. The apomorphines are a bit less powerful, but is much easier to start and stop. So it's a useful thing for some patients where they might not tolerate or might not want a more invasive treatment. And so I think it's useful to have that sort of batting order in mind, and also where does it sit in the landscape, in the treatment landscape, because I have some patients where, again, they've done some Googling and they think, oh, I've read about this brain stimulation or I've read about this device therapy. Should I have this now? Weeks after the initial diagnosis. And I say, no, we don't need to worry about that. There have been studies done, let's say, of the brain stimulation showing there is no particular benefit to having it done really early in the disease course versus having it done later on after motor fluctuations have developed. And the other point I raise is that some patients will, and in fact, most patients will never need a device-assisted therapy. So my view on this is that there's no particular benefit to jumping the gun, and we use the medications for as long as they're working and giving good control, and we can keep these device-assisted therapies in reserve. The one other thing I'll just comment on is some patients might have, and some of your listeners might have heard about this very, very new treatment, the MR-guided focused ultrasound, which has been used more in the realms of treating tremor, like essential tremor. And just to explain what this is, so the patient lies down in an MRI machine, which does a real-time MRI, and then they get ultrasound beams coming from different directions, which concentrate on one particular point in the brain and heat it up. And that can be used to target an area of the brain to treat tremor. Let's talk about tremor, to treat tremor. And as that area of the brain is heated up, but not in a destructive way, the patient is seen to have improvement in their tremor while they're on the table. And then everyone says, okay, we've got the right target. We'll turn up the ultrasound machine and then cause a destructive lesion in that area of the brain, which is a few millimeters in size. So it is a lesional therapy. I mean, an area of the brain is being destroyed by this treatment, but it is non-invasive in the sense that the patient doesn't have to have a hole drilled in their skull. And so this is a treatment that's very, very effective for treating essential tremor. and is good for those patients where they've got really bad tremor, refractory to medication, and they don't like or can't tolerate DBS, or deep brain stimulation. But people have also started to study this in Parkinson's disease. My sense of the literature is it's not quite there yet in terms of how advanced it is in the use of Parkinson's disease. It's probably more of a sort of limited indication therapy, let's say. But the research is expanding in this area, and maybe that's something that we'll see more of being developed in the future.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
Oh, what a fascinating discussion. What about the role of wearables?
Yeah, so wearables are something I find really exciting, especially when I kind of reflect on, again, I'm going to give a really long-winded answer to this, but especially when I reflect on my experience in research and doing a PhD, because, when we study patients with tremor or with Parkinson's, and I did my PhD studying tremor, including Parkinson's tremor, we can measure tremor in the lab with sensors, measuring the muscle activity, measuring the hand movement, and we can study tremor that way. But what's really exciting these days is that these tools that used to just be in the lab, like accelerometers to measure movement, nowadays they're in everyone's pocket. Mm-hmm. So, smartphones all have 3D accelerometers to measure where the smartphone is in space. Mm-hmm. And that's why your screen flips when you change your smartphone orientation from portrait to landscape mode, because it has an accelerometer that detects that the smartphone has moved. And a lot of the smart watches also have accelerometers in them. Mm-hmm. And that can be used to detect, step count and all that sort of thing. Mm-hmm. But what's really exciting from my perspective is you can use the data that's coming out of that accelerometer in exactly the same way that we would use it in the lab to measure things like, let's say, tremor. Because if you've got an Apple Watch on your wrist, and if you've put it on the tremulous hand, you can measure the tremor. You can do a Fourier transformation of that data and measure what's the tremor frequency and what's the, how bad is the tremor, how high is the amplitude of the tremor, and you can track that at different times of day. And there's a lot of integration of this technology, which is really exciting. So just to harp on about Apple a bit more, no conflict of interest. I'm an Android user, but Apple a few years ago developed or released an API to allow software developers to be able to access that accelerometer data, that movement data, directly from their smartwatch. And so people have worked on that. And last year, there was an app release that got FDA approval in the United States, which can measure the tremor and also other parameters like slowness of movement or freezing of gait or falls for patients who have Parkinson's from their devices, from things like their Apple Watch or their phone, and translate that data into insights for the patient or for the doctor. And, at the moment, I wouldn't say that this sort of wearable technology is necessarily really widespread in use in Australia, but I think it's really exciting for what it holds for the future, because if we can move some of this sort of data collection out of the lab into the community, we can start to collect really big data sets. You can imagine if you've got an app that lots of people with Parkinson's have, that's measuring how fast they're moving, how much tremor they've got at different times of day, and you're collecting that data across lots of patients, you can see how you can quickly generate a data set that's big enough to start to apply some of these tools like AI to really, fast track, generating research insights from this stuff. And, we're seeing the impacts of it, I think, already. I mean, I'll give another example. tangentially related to wearables. We, as part of my PhD, we published a paper through my department at Westmead Hospital using video data, so videos of patients with tremor, and using an open source software platform that labeled the body parts of these people, of the video of these people. And we used that to measure their tremor and found it worked really well for measuring tremor for resting tremor for patients with Parkinson's disease, as compared with the standard technique of measuring tremor used in clinical trials, which is a human being eyeballing the patient and saying, I think this tremor is mild, moderate, or severe. And what's really exciting there from a research standpoint is you can imagine these clinical trials are pretty labor-intensive business. I mean, you know, let's say you're trying a new Parkinson's drug. You got to, okay, you start the drug. The patient, you got to drag them in from home in 3 weeks' time, and you got to do a clinical assessment and check their tremor. And, you know, a neurologist has to look at them and say, I think this tremor is mild, moderate, severe. And, you know, then the patient can go home after hours of this office visit. You know, imagine the future of clinical trials if instead of doing all that palaver, the patient's at home with these sensors that they've got on in their pocket or on their wrist anyway, and we're collecting this outcome data in real time, and it's being automated, and we can, you know, analyze in real time in an automated way. Okay, what's the impact of this new drug on the tremor or on their slowness of their bradykinesia or whatever parameter we're trying to treat? So I think wearables are really, really exciting in terms of how they're going to sort of supercharge, you know, research development in the future, and how they're going to sort of change how we do things in practice in terms of monitoring some of this data stream that's coming in. I think it's more of the future rather than being the here and now at the moment. Although, you know, that said, so many of my patients have these smartwatches these days, and I've had a few patients that I've treated with essential tremor with propranolol, who they've come in to see me and said, you know, doctor, you've overdone it with the propranolol. My Apple Watch said my heart rate went down to 40 while I was asleep. And I think, oh, goodness, okay, thank you. You know, your heart rate in the office is, you know, 65. I wouldn't have known that there was a problem, but, you know, that's good to know. So, you know, we'll reduce the dose. So, you know, already, I think this wearable technology, the patients like it, and I think it's already influencing our clinical practice.
I actually had a thought in my mind for maybe someone else's research, Alex. It's, you know, you're also able to determine the patient's step count and number of flights of steps walked. And, you know, I wonder whether patients who are more active versus those who are more sedentary, does it or does it not have an impact on the severity of tremor over time? It's just a thought that just, you know, you can use.
Yeah, absolutely. And I mean, just to sort of segue from that into the broader question of the benefit of physical exercise, let's say for Parkinson's, I mean, I tell patients that it's the closest we have to a disease-modifying treatment at present. Okay. So there's been a lot of research to show that physical exercise seems to improve the outcome for Parkinson's disease and seems to slow the progression of the Parkinson's as far as we can tell. We also know from a number of studies that it reduces the risk of cognitive impairment, which is often a big concern for patients who have been diagnosed with Parkinson's disease, or indeed older patients more generally. So I think I emphasize to patients the importance of physical exercise for Parkinson's. And I think you're 100% right. I think wearables are going to have a really important and growing role in guiding patients. Okay, are you doing enough exercise? How's it impacting your function? I think there's a lot of insights that can come from that.
And lastly, with regards exercise, we've all heard of, you know, dancing and Tai Chi being particularly useful. Does it matter? Does, say, resistance training, is it more important than, say, aerobic
Yeah, it's a great question, and it's a question patients often ask me as well, and I'm sure patients ask your listeners too. And I tell patients that I'm pretty agnostic about the type of the exercise that they do, because there are lots of studies studying all different types of exercise, aerobic exercise, weights training, Tai Chi, yoga, golf, dancing. There's lots of studies, and it all seems to work.
Okay.
So I'm quite open-minded about the type of exercise that they do. I generally try and steer them towards aerobic type of exercise, 30 minutes, 5 times a week. But mainly because that's the sort of exercise paradigm used in most of the studies that I've read. But I have no doubt that other forms of exercise work too. The other comment I would make about exercise, just with relation to balance more generally, there's good evidence that things like yoga and Tai Chi improve balance and reduce falls risk.
Mhm.
Golf as well for patients with Parkinson's, interestingly. Aquarobics, which is very popular, and I know is very hard work from seeing it in action after I'm finished with my toddler swimming lesson, is unfortunately probably not as effective for balance specifically. I mean, I think it's still a good cardio workout, but the research tells us that land-based therapies, as they call them, are probably better than aquarobics for improving balance specifically.
Dr. Fois, with regards to Parkinson's disease, you did mention in the first interview that it is possible that PD starts from the gut and that constipation is a major issue. I wonder whether or not dietary intervention in the future may be helpful, question one. And question two, are patients with Parkinson's disease at risk of nutritional issues?
Yeah, it's a great question. Question one, in terms of what dietary interventions could we use in the future, and I think it's a question I can't really forecast and don't have a really good answer to, but it's certainly a very exciting area of research. But I can comment about dietary interventions in the here and now, and what are the sort of parameters that I use to guide patients with Parkinson's, because I know patients are very interested in this, and a lot of patients want to really optimize their diet, exercise parameters, etc. And what I say to patients is, first of all, making sure that they're avoiding constipation, so taking enough fluid, fiber, and laxative to aim for 1 soft bowel motion per day.
Mhm.
And I really try and encourage patients to avoid the trap, or the common trap, of going 3 days without a bowel motion, taking a whole load of Movicol, having explosive diarrhea, and then thinking I'm never going to take Movicol again, and then waiting another 3 days and repeating the cycle. And instead taking a little bit of laxative, fluid, fiber, etc., daily to try and regulate the bowels. But then also in terms of diet, a lot of people are interested in the impact of protein on the absorption of the Parkinson's medicine. And this is something interesting. So protein does interfere with the absorption of the levodopa. And so patients will sometimes think that they've got to make big dietary modifications to handle this. But one thing I emphasize to patients is actually early on in the course of Parkinson's disease, it doesn't matter too much. Actually, the effect of the levodopa is just so smooth early on that usually it really doesn't matter too much how much protein they're having or where they're having it. It's not going to have a big impact on the effectiveness of the drug. But in patients who've had Parkinson's for many years, where they're getting a lot of wearing off, or the control of the symptoms is a bit brittle, then actually it can be quite a relevant parameter to say, okay, maybe we need to make sure you're taking the levodopa on an empty stomach so it packs more of a punch. And maybe we need to start thinking about protein intake and how that's used throughout the day, and trying to, for example, have the main protein meal in the evening rather than having too much bacon and eggs at breakfast or at lunchtime, which might interfere with the absorption of the levodopa. But I emphasize to patients that sort of dietary modification, the need for that is more the exception rather than the rule. And then in terms of dietary deficiencies, there's some theories behind vitamin D deficiency and Parkinson's risk. I must say I don't routinely screen for dietary with blood tests, let's say, for dietary deficiency in my patients with Parkinson's. I mean, maybe I should. It's a very, I guess there are data, aren't there, for patients who are, let's say, housebound and vitamin D deficiency and falls risk. So it's not something I routinely screen for, but I think you're right with a sort of older population who are more at risk of Parkinson's disease and might have dietary deficiencies for other reasons. It's an important thing to unpick and keep abreast of.
Dr. Fois, you've just given us this incredible and beautifully, I just love the timeline of how, the history of the drug, the timeline for the patient, and how you add on to it, including the use of devices and wearables. What are your key messages to our GP listeners with regard to the management and treatment of Parkinson's disease?
I think my single most key message in terms of treatment is really to be guided by the patient and their symptoms. And I've sort of emphasized this a couple of times, that what we're doing in Parkinson's treatment is not modifying the disease process. Unfortunately, we don't have a disease that modifies the long-term outcome yet. But what we're really doing quite effectively with treatment is improving people's quality of life. And the treatments are very effective for that. So my key messages would be to be guided by the patient in terms of when they want to start treatment, and to have generally a more relaxed approach to that, and then also in terms of what treatment to give and what doses to choose and so on, really to be guided by how they're feeling and whether or not they're satisfied with the control of their symptoms. I think we're not sort of aiming to get them to a particular dose or a particular type of therapy. What we're aiming for is for them to be as satisfied as possible that their symptoms are under control and they've got a good quality of life, while causing the minimum of side effects. So that would be my key message.
Dr. Fois, I thank you for that. That's really helpful. What a wonderful, wonderful talk. Thank you.
Thank you.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.